Thank you very much, Shelley, for that very warm welcome. And it's a delight to be back in New Zealand and to connect again with the Royal College of General Practice. My name is Anne and I am a rebel, but I'm a Scottish rebel, so I don't know if that's enough to make you to be afraid for this afternoon session, but I'm certainly going to ask you to do some, most of the work, but I'm going to introduce the session by just giving you a flavour of some of the work that we're doing in Scotland and with some of our European colleagues to use technology to help us get it right first time, all the time for our patients. And we're taking forward this very much within a framework of quality. We see safety as one of our 3 quality ambitions for safe, effective and person-centred care. And I'm delighted as a community-facing geriatrician, I'm really delighted that our vision for quality in Scotland is very much focused on home, living healthier lives at home and in a homely setting. That yes, hospitals are important and safe care and the avoidance of harm in hospital is absolutely important, but most people live their lives not in hospital. So the focus on avoiding harm in primary and community settings is really important to our 2020 vision. And with Helen has done a lot of work with Health Foundation, and this morning Helen set some of the frameworks around leading change, and we have been looking at work that the Health Foundation have been developing around that framework for measuring and monitoring safety. And I think that's a framework that I would commend for your use, but I know that my colleagues are going to go into more detail later on in this afternoon session about some of the very practical tools that you can use to look at past harm, to look at reliability of the system, and looking at sustainability of the safe conditions within your system. Within Scotland, we've been looking at adapting and adopting the Scottish Patient Safety Programme into a primary care setting. And really the focus to date has been on looking at the systems within primary care, looking at the culture and the leadership. Is that a culture which is embracing and nurturing safe care? Particular focus on medicines and medicine reconciliation, particularly at points of transition between home and hospital and back again. And I think in the context of polypharmacy, as we heard this morning, that medicines reconciliation is an increasing challenge. So the system focus around safety has been looking at a few practical tools that practices can adopt, use, and feedback the learning and the experience of their use to understand how collectively the practice team can make care safer. And again, we're going to hear more from Bevan and Kyle about some of the actual practicalities of that. Just as you're approaching it in New Zealand, we're looking at a collaborative model. Again, the link back to the work that we heard about from Helen this morning about a truly empowered, distributed leadership collaborative, not a top-down, here's one I made earlier, you must do this kind of collaborative, where we're sharing learning and experience across Scotland, understanding what's working, but probably just as important, if not more important, understanding what's not working and what's getting in the way, and allowing people the space, the headroom to be a bit creative and to overcome some of those challenges. And then at a very local level within our health board arrangements equivalent to your PHOs, we'll be bringing together staff locally to learn about use of those tools and giving them some practical support around implementing the tools and sharing learning at a local level. We've also looked at some practical levers that we could use to help this implementation and spread of some of this work, and that's been looking at building it and weaving it into appraisal and revalidation processes. But most recently, in 2013, the Quality and Outcomes Framework, which is an element of the GP contract, was adapted to include adoption of the trigger tool and the safety climate as part of that quality and outcomes framework, which was a beginning of a shift away from the quality and outcomes framework tick box for chronic medication interventions or chronic disease management interventions towards something that was a bit more generic around quality. And then more recently looking at an enhanced service, which is again another element of the way that primary care services are contractually supported, to provide some financial incentive and financial support for the practice team to participate in that collaborative so that they could improve the safety culture and reduce harm, and particularly focus on some of the high-risk processes, high-risk medicines, or high-risk patients with multiple conditions. And importantly, to involve the practice patient population in that work, not just to do it over in a professional silo, but to actually involve patients to inform and shape the way that those changes could be introduced into the practice. As part of that work, we're looking at supporting and further developing the range of improvement skills, improvement science, methodology, understanding for the primary care community. But remembering that going back probably 7-8 years, primary care led a very progressive collaborative programme around primary care access in Scotland. So many of our primary care practitioners already do have improvement science and improvement methodology skills in the Plan, Do, Study, Act cycle of improvement, but also looking at improvement tools like the productive general practice, where you're applying some of the process redesign skills to try and create that headspace for different conversations around safety or around appropriateness of medicine space to be able to undertake medicine reviews. But we're also recognising that it's not just about the process improvement techniques, it's also about the relational improvement methodologies, having a different type of conversation as a team, but also a different type of conversation with patients. And so some of our supports around the personal outcomes approach to assessment and care planning are equally valid in improvement tools. We're seeing that in order to take forward a safety agenda, a quality agenda, that we need a workforce that has that capacity and capability to lead quality and safety in Scotland. And that includes making more and better use of the technology that we have available. So it's not just the improvement tools that we need to make better use of, but the ICT that we have in the system, and increasingly the use of digital technologies. Hands up if you have a smartphone or have used in the last 24 hours some form of email, social media. And I think it's just becoming part of the way we do our business, and it's also the part of the way that our patients, our carers, the general public expects to be doing business in the future. So our vision is very much a vision for quality, but a technology-enabled health and care team that uses that technology to help them do the right thing the first time, all of the time. And I was heartened by Helen's reference this morning to moving from sort of slow tests of change spreading towards a bit more disruptive innovation as the way that we're going to transform care and support. I think gone are the days of cautious conservatism. We know that doing more of the same won't work for us, so it's time to be taking some of those brave pills and testing some quite creative options. Some of the technology that we're exploring in Scotland and seeing how it can support quality of care and safer care is looking at the use of some of the social media platforms. Again, linking back to what we were talking about this morning, not so much thinking about improvement programs, but improvement platforms. This is what we call our Living It Up platform, and it's the product of a programme that we've been doing with the Technology Strategy Board in the UK, and Scotland was one of 4 sites in the UK that took forward this programme. And it's a platform for people with chronic conditions to use to help them live well, living it up, to help them be able to access information and advice to manage their conditions, but importantly to connect with each other, recognising the impact of peer support to help people to live well and manage their conditions. So it's not just the professional to patient relationship, but it's the peer support as well. I know that you're having a patient portal rolled out within and across your PHO organisations, and similarly we're developing and expanding the access to patient portal in Scotland. One of the early successes we found was in the diabetic population, people who have diabetes, often quite activated in terms of wanting to know their blood sugar results, their HbA1cs, taking a lot of ownership in terms of wanting that information directly accessible to them from the laboratory, from the practice. And so patient portal in renal patients and diabetic patient populations is now beginning to get expanded. And I'll be really interested to hear your experience of how your patient portal can help you create different conversations and create the capacity to support safer care. Similarly, the clinical portal that we have and is probably a pragmatic alternative, a much more affordable and feasible alternative to a sort of electronic patient record for Scotland. We have had to build on what we had in terms of electronic records. We have 2 primary care systems. We have an EMIS and a Vision information system in primary care, and we have a couple of hospital-based patient management systems. So we don't have a single electronic record, but we can use the portal technology to adequately connect the primary care and the secondary care information. And increasingly now, our primary care professionals and hospital practitioners can see the same information through the portal technology. We're not quite there yet in terms of our community services being able to see all of that, or even more importantly, to input into those records. We're certainly not yet at the point where that can happen with ambulance practitioners and all of the range of services that we need to have out of ours. But it's certainly a tool that is absolutely critical for safer care. One of the things that we've been able to build on is technology that was generated to share the emergency care summary. The emergency care summary is now something that every person in Scotland will have unless they opt out of it. And I think it's vanishingly small numbers of people choose not to have their emergency care summary shared. And that's simply a list of the medicines that they're on and any allergies that they may have. And that is automatically sucked out of the primary care systems and shared with the hospital system, with the ambulance services, with our NHS 24, which is our telephony provider for out-of-hours services. And so it's a small but really critical step in terms of safer patient care, the ability to know what drugs someone's on when they pitch up unexpectedly in an emergency situation, what drugs they're on, what the allergies are, and also being able to then start to build on that platform, and we've been able to add on some important information. We've built onto that emergency care summary our key information summary, and John, you talked about KISS, keeping it simple. Well, our key information summary is absolutely a very simple set of important information beyond the medicines, the kind of information that you really want to have in an emergency situation to help you decide about treatment ceilings. So understanding what chronic condition somebody has, what their previously expressed wishes might be about treatment ceilings in COPD or chronic renal failure, understanding their carer, understanding if there's any particular important sensory problems that need to be taken into consideration when you're managing that emergency episode. So the combination of our emergency care summary and our key information summary, which is a summary of that thinking ahead plan, is now again automatically sucked out of our system every few hours and spread across to the relevant secondary care and emergency practitioners. That's what it looks like on screen in a GP surgery, and if you then present with an unscheduled emergency or out-of-hours episode, you'll get an alert, a warning that this person has a key information summary, and you won't be able to sort of go into the rest of the record until you've read that. So that's an amazing support in terms of making safe decisions and effective decisions when you're perhaps a call handler taking an emergency referral call in the out-of-hours situation. We've got a lot further to go. We've still got to do more around some of our multi-agency information sharing, our multi-agency messaging, particularly for people where it's not just safe health care that's the concern, but safeguarding perhaps a vulnerable adult or a child where there may be child protection issues. So we're looking at using the same kind of portal technology to have a multi-agency store where the different agencies can get access to messaging through that multi-agency store, whether they're police or education or health or social care providers. I feel a bit like teaching Granny to suck eggs, talking about remote video consultation in New Zealand, where you've got some very remote and rural communities. But again, having that professional to professional support using video consultation is critical to providing safe care, particularly when we're facing the workforce challenges that I think both of our countries are facing, when we just know that we won't be able to have the range of specialists available 7 days. So we may have to look to having some of that specialist expertise at a distance through remote video consultations. And these are examples of some of our remote video consultation for unscheduled care from our island health board areas over to the mainland, where we won't maybe have a consultant presence, but we're able to provide that expertise remotely. Similarly, when we look at some of the decision support that our care home sector requires, it's not always feasible to have an age specialist nurse or geriatrician physically in the building. But increasingly, we can have those sorts of consultations provided remotely through video consultation. And this is an example where our old age psychiatry team, our mental health team, has been providing support to a care home several hundred miles away in the remote Highland area, and has successfully reduced psychotropic medication, benzodiazepine medication, and really improving outcomes for people with dementia and cognitive and behavioural disorders. We need to do a lot more of this. I could see that this is not just applicable for remote and rural settings, but even in urban situations where the patients may not be able to travel well to see the clinical staff, but the clinical staff could engage quite well with the care staff. Another example where we're using technology is in home health monitoring. And in Scotland, 7 of our partnerships in Scotland, our health and social care partnerships, are participating in a multi-centre European study, United for Health. And that's really got a focus on home health monitoring for COPD, for heart failure and for diabetes. And that United for Health home health monitoring is giving people more information to be able to understand when their disease, their conditions beginning to flare up. And the feedback of the information from that home health monitoring is again another way that we can improve the safety of care by raising awareness of when somebody's condition is beginning to go off the boil. It's not just home health monitoring that's an element of our safety portfolio. It's using assistive technology in the home to be able to reduce the risk of falls, to be able to detect floods, fire, all of the sort of hazards around the house that we know with an ageing population are increasingly factors in the risk of harm at home. So our technology-enabled care programme is trying to increase the spread and use of assistive living technology as well as home health monitoring. And not to forget the importance of supporting carers to be able to fulfil their contribution to care and support and safety at home. And just using simple day-to-day technology like an app. The Carer Scotland app is now available, and that's designed just to help carers have a sort of more confidence and feel safer by having things like checklists for medication prompts that they can then use to send a text message or phone the cared for individual, and just some simple practical tools that carers find useful in helping to contribute to safer care. We're looking at how all of these technologies can be woven together along the care pathway. So an example of that is in the Smart Care project, again another European project that Scotland is participating in. And for somebody who is older, at risk of falling, then we could see at all of those points in the care pathway where we could use technology to make care and support safer, more coordinated, and get the feedback from the individual and the carers working in the home setting to be able to understand when care is safe or when there are beginning to be gaps in the system, a bit like those holes in the Swiss cheese that we saw earlier this morning. Those are the sort of common ICT enablers that we can start weaving into any care pathway, not just falls. It could be a COPD care pathway, a heart failure care pathway. And the Smart Care project has some quite clear aims around making better outcomes, sharing the information and assessments so that we can get effective early interventions, calendars and simple prompts to provide better coordination of care, more empowered individuals who understand their condition and can support self-management, but also better connected individuals. We heard this morning that peer support for professionals is really important when someone's confidence has had a bit of a bashing after a complaint. Similarly, peer support and confidence for individuals who need to be connected better to the local community can be really critical when somebody's feeling quite vulnerable and isolated. So that's a quick romp through some of the technologies that we have in our toolbox to make care safer. And I'm going to pause for a little bit of tabletop discussion, maybe take about 5 minutes to think through how will the technology that you have available in your primary care organisation, in your practice, help you deliver safer care so that care's safer the first time, all of the time. What do you think your patients are going to expect in the future? What are you going to expect as you age and you develop your basket of long-term conditions, sadly, that I think we all will develop? And what are you going to expect in the way of technology? And how might we support the adoption of technology with the public? How can we promote greater digital inclusion? And thinking about the context that you're operating, what does that look like for all of your population, including the Maori Pacific population and perhaps people with high levels of need? So just take 5 minutes and have a sort of general discussion around that. Okay, folks, I'll bring you back together again. We've got time within the session, maybe just to get a couple of reflections from 1 or 2 tables. Shelley's got a roving mic. Is there anybody like to volunteer, just maybe to give us a bit of a flavour of the discussion at your table? Here we go.
Yeah, Fiona Bolden, I'm a GP in Raglan. Just a plug for rural broadband. Even in our area, we've got quite substantial geographical areas where we've got no cover for anything. So all this technology is fairly useless to us rurally if we've got no rural broadband.
Okay. Great. So I'm sure there's enough people in the room to be able to reflect that message back to ministers when they join the discussion. Any other table?
Hi, I'm Bevan Telfer, GP. We had 2 discussions here. One was, just increasing the sharing of information more effectively, reviewing the systems that are presently within New Zealand and are effective. With discussion about the Pegasus information sharing program, now covering the whole of the South Island. And then we had a discussion about using technology for the patient becoming the centre of, their own care, and particularly, the term that's used now is flipping care. And I think that that's something that I'd like to see develop, and I have more time for my complex patients, and we have simple monitoring processes that don't waste our consultation time.
Okay, thanks, Bevan. I'm going to move us on to, that was a kind of general discussion. Move us on to a couple of scenarios. I use my Alice in Quality Land sort of scenario, which, is pretty standard sort of examples of the kinds of complex patients scenarios that you'll face day and daily. So an example would be Alice, who's a sort of lady in midlife who has a number of cardiovascular risk factors, who's also carer for her husband who has Parkinson's disease. And, suddenly life changes when she's diagnosed as having diabetes and high blood pressure. And, how can we use technology to help her to stay well, to be signposted and connected to some of the community supports and lifestyle supports, to understand her medication and to connect appropriately with her community pharmacy services and some of the other allied health professionals that she needs to connect with to stay well. So again, just take maybe a couple of minutes at tables and think about some practical examples from your experience about, what you would do in that situation, what technology you would draw on, or what technology you would like to be able to draw on if it's not there yet. Okay. And as you know, life is never straightforward, so Alice's condition progresses, and after a few years she develops effort-related chest pain and breathlessness, and so we're beginning to use more of secondary care services for echo and exercise testing. Medication has to be changed again, and then there's other wider lifestyle issues around work and ability to continue at work. Lots of other people start having an interest in what Alice's results are. It's not just within the immediate health service, it's her employers and occupational health want to know what's going on. And then there's wider issues around work and benefits and financial health and well-being. So again, what kind of information and what sort of technology do you need to get the right decisions for Alice this time? It's got to go wider than primary care, secondary care. And again, here we have yet further developments. Maybe the next big milestone that Alice has is that she has an acute cardiac event. She's admitted to cardiac unit where she gets primary coronary intervention and stenting, and then she's transferred back from her cardiac unit to her local hospital. Anybody been in that situation where the notes go missing and transfer back? And then you're trying to kind of work in the dark. She has quite a complex, prolonged, what was the phrase this morning? A stormy time in hospital with arrhythmias and trying to get her anticoagulation right. And then she has to have some sort of cardiac rehab services once she goes home, links with a heart failure nurse program. And in the middle of all of this, she's still worried about her husband, who's becoming increasingly disabled with his Parkinson's disease. So there's issues around her being assessed for carer support. And she's now on so many drugs that she's just so thoroughly confused about what she's to take and when and how those drugs are monitored. What's the technology you need to sort that complex scenario out? And we're going to time travel again, and she's now jumped forward a few years, and despite being successfully anticoagulated, she's now unfortunately had a new stroke, and it's an ischemic stroke. And again, she's hospitalised, but partly because of her fears about her husband managing at home, and partly just because she wants to be at home. She's really keen to have her rehabilitation in her own home rather than being rehabilitated in hospital. So what is the technology that can help you make that supported discharge back home a safe supported discharge? What equipment, what kind of telecare, what kind of home monitoring might you want to think about? And thinking about the communication across the now quite large team of professionals who have a stake in her care. How do you coordinate that care as a sort of care cluster around the practice? And how can technology help you do that smoothly? How can you share the care plans across the different professionals and the different agencies? So I'm getting the sense that by now you've probably got a growing wish list for things that actually you would really like to have, but you maybe don't have. Or hopefully also some things on that list that maybe you do have, but you just need to use them more or use them differently. So really just an exercise to sort of get you thinking about how technology and safety are really interdependent, and that some of the ICT developments that are emerging are absolutely central to the quality and safety agenda, and not over here some sort of infrastructure that is only of interest to certain members of the team. In Scotland, we've been looking at how we might expand and scale up the adoption of some of the technologies that are currently available, and we've been doing some work with our European colleagues who developed the success factors for deployment at scale of telehealth and telecare and ICT developments as part of the Momentum project. I wish it was a thistle that they had developed, but sadly, it's a Celtic symbol. And the 18 critical success factors for deployment, we've taken them and we've cut it down to a kind of magic 10 or so. And a little advert for, I think it was earlier this year, one of the College Pulse publications had a little article about what we were doing in Scotland and how we were using the organisational readiness as success factors to help us spread. So that might be something that you might want to have a look at. We've also got quite a lot of materials and resources available on the Joint Improvement Team's website, on the Scottish Centre for Telehealth and Telecare's website, and in our community of practice, our learning network for telehealth care. The web addresses are there. I'm delighted to take any queries through your college team or directly. That's my email contact. So I'm going to sort of close at that, but maybe just ask to use the last 5 minutes or so if there's any comments, reflections, or any questions, not so much for me, but maybe questions for Shelley as chair, in terms of being able to take back some of the discussion to where there might be a sort of productive opportunity for taking some of this conversation as part of the rollout of some of the technology that the PHOs are taking forward. So can I thank you very much for your participation.
Thank you so much, Anne. So we do have some time for questions before we invite Bevan and Kyle up and tell us how they've stolen with pride some of the initiatives from Scotland. Has anyone got a question? Thank you, Tony.
Yeah, one of the issues that comes up with the more we share information with all of these different people are the issues about patient privacy and their concern about having their personal information, which they've shared with us, being able to be accessed by anybody. How do we get around that?
Yeah. I think by having a conversation with the public and with patients around it, and just over time that conversation matures from a point of, oh my goodness, I'm worried about the safety and the privacy, to actually it's safer to share. We've been on that journey probably for about the last 5 years in Scotland, and it started off with that, we couldn't possibly, and it's now really in the domain of it's safer to share. Our Health and Care Alliance is our NGO, which is a sort of patient advocacy NGO for people with chronic disease, and they've led the charge on this. They're very much running with advocacy around information sharing being far safer and in the interests of patients. I think the worried well public still have some concerns about it, but people who have multiple conditions, who have multiple contacts with professionals from different agencies, understand that better information sharing leads to better coordinated care and better outcomes.
So, Anne, we often also hear that, perhaps our older population or those sort of with high needs from a socio-economic perspective won't have access to the technology that will enable them to sign up to programs such as this. In fact, that's often not the case, is it?
It's not. I think the point that was made about broadband access is a problem. It is an issue. Some of our island areas are beginning to explore satellite technology as opposed to broadband. But the issue around user of utility is beginning to absolutely melt away. Some of the very simple technologies that are just touch screens are really usable by people with learning disability and with cognitive impairment. I had the privilege of sitting next to Agnes, who has dementia, at a conference just a couple of weeks ago, and she was proudly showing off what she can do with her iPad and how she uses her iPad to Skype and keep in contact with her family and with people who she gets support from.
But I guess my question to you is that really complex people with multiple morbidities, you know, it's very complex to coordinate their care, and I think it can sometimes come across, perhaps unintentionally, that it's quite simplistically easy. Whereas I would still say that there needs to be some human intelligence and caring going on to coordinate. Mm-hmm. It's very easy to think, oh, it's happening because this technology is involved, but it doesn't necessarily mean that good quality care is actually happening. Yeah. Have you got a response to that?
Yeah, absolutely. And I think a point was made earlier around creating some capacity, using technology for people who can use technology to support them to self-manage or to change some of the skill mix in the care that's provided, releases capacity for the group that you're just describing, the very complex, who need very much hands-on, who need very much senior professional decision makers to be hands-on with their care. So it's not suggesting that it's a panacea for everyone, but if it's targeted appropriately at those who can use it, it creates some headroom, some wriggle room to really manage some of the very complex and increasing caseload that we have.
So, Joe Scott Jones, I'm a rural GP, and in Australia I know that there's some consternation about implementing IT change because it's starting to replace the traditional care as opposed to complement the traditional care. Are you facing the same sort of challenges in Scotland? We're certainly seeing it here.
Mm-hmm. There's an element probably in care at home, in telecare, that I would say is probably we're seeing a replacement of personal care using telecare support for things like community alarms or just checking visits that are done through telecare. I would say it's less of an issue in telehealth, but we are seeing that in telecare at home to the extent that probably 4 out of 5 people in receipt of some formal social care support are receiving telecare as part of that package. That's probably a good thing, because otherwise I don't think we could have coped with the increasing demand associated with care at home in the fiscal context that we're operating in. We are seeing, in Scotland, I'll talk a bit more about this later in the conference, but we're seeing older people spending 2 million more days at home than were expected. Part of the contribution to meeting those 2 million more days at home of care is through telecare.
As a result of that?
There's evidence for the home health monitoring, say for example the heart failure or COPD. There's evidence that quality of life and confidence improves for the individuals. There's not great evidence that it reduces hospital admissions, and partly that's because you have to re-engineer the whole system, not just the home health monitoring bit of it. You've got to have different processes around professional decision making at the point of emergency or at the front door before you actually see a difference in hospital admissions. But there's definitely quality of life outcomes are better. When you look at the unscheduled care remote video conferencing, then probably our best examples in Scotland are around our rural populations and our island boards, where for very practical reasons, you're just not going to get the range of secondary care specialists able to. We don't have stroke clinicians on island. What we do have, though, is an excellent tele-stroke service. So the consultant in Aberdeen can look at the CT image and make the assessment over the VC, do the assessment of the teleneurology, and then decide whether they're being thrombolised or not. So we've got very good examples of that with good outcomes.
And thank you very much for a very, very good presentation. Really appreciate it. My name is Sharon Kletchko, and I'm the General Manager for St. John in the Central Region. Hamilton's our regional headquarters. What St. John, New Zealand's looking at is a way of using existing clinical capacity and capability in terms of predominantly our volunteer clinical workforce to fill the gap in supporting patients who are at high risk with multiple chronic conditions to live better in their own homes and to link in a collaborative, cooperative way with GPs, with community pharmacists, and with other health providers. So what you've done is essentially show us that what we're planning, I think, is the way forward. I'm just wondering if the joint improvement team can kind of be expanded to include some of us in New Zealand who are on that pathway?
I would certainly love for this week not just to be a one-off, but to be part of an ongoing dialogue and collaboration across, I think, two creative countries that are both punching well above their weight.
Thank you. I think that's a nice point to end that conversation, and I ask you to thank Anne again for a lovely, lovely presentation. Thank you.